I'm Glenn Cohen. I'm a professor here at the law school, and I'm the faculty director for the Petrie-Flom Center. We're really delighted that you're here. We're going to have a sign-up sheet for our listserv going around, if you haven't heard from it yet. This is the first event of our packed event calendar. We're so happy to be here with our collaborators at CLBB. And after today, we're going to have an open house where many of the people speaking today will stick around, but you'll also meet students, faculty, fellows from across the university who are interested in health law, bioethics, and biotechnology. So without further ado, I'm going to introduce the moderator for the event, Professor Robert Kinsherff.
Good afternoon, everybody. Good afternoon. We can do better than that. Good afternoon, everybody.
Good afternoon.
And I did that at least in part because we've structured the afternoon to be some initial presentations, but we're hoping really to generate, after we've had some conversation amongst ourselves up here at the panel and with you, to have discussion about this very important and compelling topic before we conclude for the day, and hope many of you will also join us at the open house. Thank you, Professor Cohen, for the kind introduction, and I'd also like to acknowledge the Executive Director of the Petrie-Flom Center, Holly Lynch, who is on maternity leave but is with us in spirit, I'm sure. And I would like also to acknowledge Dr. Judith Edersheim and Dr. Bruce Price, co-founders and co-directors of the Center for Law, Brain, and Behavior at Massachusetts General Hospital. This event is a result of a partnership between the two centers, and I've been fortunate enough to be the beneficiary of that partnership, and I'm entering my second year as Senior Fellow in Law and Applied Neuroscience in a joint project of the two centers. Today's event is a joint collaboration, as I mentioned before, and I hope you'll join us after this event at the pub. The secret information that Professor Cohen did not give you is that the food and the drink is both ample and free. Having a dim recollection of what it is to have been a student, I emphasize access and economy. It'll also be an opportunity to network with people and to learn more about the Petrie-Flom Center and the Center for Law, Brain, and Behavior, and I think to further the conversation, a very important one that we're going to have today, and on other compelling issues. So the usual housekeeping, if you would please set your cell phones either on silent or on stun, whichever you prefer. If you need to leave, if you could possibly do so without going through the aisle that has the camera, because we'll be audio and video recording this, and this will be posted on the center's respective websites in a week or so. Finally, during the question and answer period, because we are audio and videotaping this, we don't want your important observations, questions, or comments to be lost to history, which means that if you'll let us know that you have something that you'd like to say in engaging with other participants, with panel members, just let us know. We will have hand mics on each side of the room, and just be patient until a hand mic gets to you, and we'll go from there. It's my pleasure to introduce our panelists, who are going to be introduced in order of the presentation, moving to my right down the table. The first is Dr. Michelle Bosquet Enlow. She is a developmental and clinical psychologist with specialized training in infant mental health, birth to 5, the assessment and treatment of traumatic stress in children and adults, and the development of child stress regulation. She received her PhD from the Developmental Psychopathology and Clinical Science program at the University of Minnesota, and is particularly interested in understanding how risk for mental health difficulties throughout the life are established in early development. Ultimately, she aims to design interventions that support healthy development and prevent the occurrence of mental health problems, particularly in highly vulnerable populations. To her immediate right, Shannon Cosgrove. Shannon serves as the Director of Health Policy at Cure Violence, where she is responsible for defining and promoting public health approaches to violence prevention. Her projects include assisting with the National Health Meeting, leading a research network, implementing best practices for trauma prevention, promoting community healing, building partnerships, and ensuring equity is embedded in the work that is done in communities. Before joining Cure Violence, Shannon was Deputy Director for the Mayor's Office on Criminal Justice Issues in Baltimore. To her immediate right, Fatimah Loren Muhammad, who I also just need to comment is an alumna of William James College, and we're very, very proud of her and what she has made of her work since leaving our school. Fatimah is the director of the Trauma Advocacy Initiative at Equal Justice USA. She's a psychotherapist who specializes in trauma among adults, adolescents, and communities. Recognized by President Bill Clinton as a leader in social innovation, she has worked with several not-for-profits to provide innovation, organizational change, and strategic vision both locally and globally. Her work at Equal Justice USA entails bringing together the diverse stories and perspectives of crime survivors to advocate for a trauma-informed justice system, a system that recognizes that justice doesn't begin or end when someone is locked up, but instead promotes the restorative work of healing communities. And finally, to my far right, Dr. Charles Homer. Charlie is the Deputy Assistant Secretary for Human Services Policy in the Office of the Assistant Secretary for Planning and Evaluation at the United States Department of Health and Human Services. Prior to that, he was an Associate Clinical Professor of Pediatrics at Harvard Medical School and Assistant Professor in the Department of Social and Behavioral Sciences at the Harvard School of Public Health. He is also the co-founder and former president and CEO of the National Initiative for Children's Healthcare Quality. At the Department of Health and Human Services, he oversees policy research, evaluation, and coordination related to poverty and vulnerable populations. So we have a wealth of experience and interesting perspectives here on the panel. What I'm inviting people to do today is play a little bit of connect the dots with us, because we've intentionally created a presentation where we think that there are important interconnecting themes, but some of those interconnecting themes may not be entirely obvious, even to those of us who are having this conversation with each other a lot. And we are often surprised by the kinds of overlays and synergies that we find in having this conversation, which is why we want to also to have this conversation with you. So we will start off with a discussion of neurodevelopment, and particularly the context neurodevelopment in conditions of adversity. We'll then be thinking about what we want to understand from that information by looking at public health approaches to addressing community violence, in particular in communities, and the kinds of models that we want to be thinking about in trying to limit community violence and the damage that it inflicts on individuals and communities. That will be followed by the sort of the so what inquiry. And the so what inquiry is, if we take this information, how do we think about crafting together avenues for advocacy that will allow us to move out of our individual silos and connect with each other in larger and larger groupings that may someday constitute a movement that will allow for the social and political action that will allow us to work together to effectively address adversity and community violence. And finally, Dr. Homer, I was commenting earlier, he's sort of the big poppy on our lineup here, because we're going to be asking him to do some thinking from the point of view of very high level, very deep policy, because we know that while local initiatives are absolutely essential for making real things happen on the ground, it works better if we understand how to coordinate those initiatives in the forms of ever greater levels of policy and focus, which we can build with the movement that we hope to create. So with that, I'll stand aside. And if, Chrissy, we may need you to activate the... I'll watch you work your magic. Beautiful.
Good afternoon. Can everybody hear me? Okay, great. So my talk today is entitled The Neurobiology of Trauma, Ripple Effects for Individuals, Generations, and Society. So I wanted to start briefly with just some terminology to make sure we're all on the same page. The term stress has taken on a lot of meanings in our culture, and so I'm specifically talking about what some people have labeled toxic stress, which refers to stress exposures that result in a prolonged activation of the stress response system, often in the absence of protective relationships. And a particular type of extreme stress is trauma, which has been defined as exposure to actual or threatened death, serious injury, or sexual violation. Now, this can happen in a number of ways. It could mean you as an individual are directly exposed and a victim of that. You witness it happening to somebody else. You learn about it happening to a close family member or friend, or you're exposed to repeated descriptions of such an event. So a few caveats for today. One is I'm going to be talking about research, which is usually correlational, which means that I'm going to be talking about how trauma exposures, when studied in a group, are associated with certain negative outcomes. That is not to say that if you are exposed to this trauma, you will definitely have this negative outcome by any means. It is not destiny. And in fact, there's a large literature that focuses specifically on the idea of resilience, which is how do some individuals who are exposed to major forms of trauma manage to either not suffer these negative effects or even flourish despite these early exposures. And these resilience factors can occur at the level of the individual. For example, high IQ or the ability to form positive relationships has been identified as a resilience factor, or at the level of the environment, having close family connections, a strong social support network, a strong community support. Some even report experiencing positive growth following a trauma exposure, which could mean a new outlook on life or a deepening of their faith. And understanding what factors promote this type of resilience is important for interventions because it can show us where we might want to focus our attention in order to bolster resources. Also, when I talk about parents in my talk, I'm going to be primarily focusing on mothers. There's a number of reasons why that's the case, but one, honestly, is that they're the ones who are studied. Fathers are not studied very often, and that's not to say that they're not important. They're very important, but we need to do a lot better work at actually including them in research. So, unfortunately, in the United States, trauma exposure is quite universal. By adulthood, 90% of U.S. adults report that they've experienced at least one traumatic event. And your risk of being exposed to traumatic events is not constant. It changes over the life course. And early childhood, particularly from birth to age 5, is a time when children are especially likely to be exposed to trauma and other stressors. Exposures also tend to correlate, meaning if you're exposed to one type of trauma, you're more likely to be exposed to another type of trauma. One example is domestic violence. Children who were exposed in the home to domestic violence are more likely to also be maltreated. And epidemiological data tell us that not all individuals are equally likely to be exposed. Unfortunately, low-income individuals or individuals from ethnic and racial minorities, when you look as a group, are more likely to be exposed to multiple types of trauma, to severe traumas and chronic exposure, so traumas that go on for a long period of time and don't necessarily have the same access to the buffers that can help minimize the negative effects of these exposures. So now I'm going to focus on what are the effects. I'm going to focus specifically on children. What happens when a child is exposed to trauma? There are a number of factors that impact what the effect's going to be. The first to consider is the type of exposure interacting with the timing of the exposure. So in childhood, particularly in those early years of life, the brain is very plastic, which means it's very open to being shaped by experiences, both positive and negative. So the impact of a particular exposure is going to depend on what part of the brain is undergoing rapid development at that time. And also the type of exposure. We know that, for example, exposure to physical abuse has different effects than exposure to sexual abuse. And then when you layer on top of that, being exposed to multiple traumas, it gets quite complex quickly. Another important factor is how was the child functioning prior to the exposure. A child who is already having difficulties prior to exposure is going to have more difficulty rebounding than a child who was doing very well prior to the exposure. Buffers are also very important. Those are elements in the individual, the environment, that help act as protective factors. So examples would be the kind of things I believe I mentioned before, like strong community support, strong social support, strong family support. And then the environmental response is critical, particularly for children. One of the biggest factors that determines how well a child does after a trauma exposure is how the parents are able to respond to the needs of the child. If a child is met with sensitive caregiving, they fare better than a child whose parents aren't able to meet those needs, possibly because they themselves experienced the same trauma exposure or are traumatized just by knowing what their child has been through. So what are the actual effects? One of the systems that has been looked at quite a bit is stress reactivity, which has to do with how do we respond to stressors in our environment. And in this instance, I'm talking about even day-to-day stressors, which no human gets out of experiencing. We all run into, whether it's traffic or the day-to-day annoyances, up to major traumas. So research shows that exposure to major stress and trauma influences many of the systems that are critical in being able to regulate your stress response. The brain, I already mentioned, is very plastic, and there are multiple parts of the brain that are reactive to trauma exposures, and it can permanently impact these structures of the brain, both in how they function and in the structures themselves. The autonomic nervous system, which is responsible for that fight or flight response when you encounter stress, also seems to be impacted by trauma exposures, and it may function differently, may become more stress reactive. I don't know if anyone's heard of cortisol. The hypothalamic pituitary adrenal, or HPA axis, is responsible for pumping out cortisol. We all have cortisol coursing through us all day, but stress can impact the functioning of that system to make it either under-responsive or over-responsive, both of which can have negative impact on mental and physical health. And this can translate into difficulties with children's abilities to regulate their emotions and behaviors. So it's not uncommon for children who've experienced trauma to have difficulties with anxiety, depression, irritability, and also more acting out behaviors like aggression, difficulties with concentration, and so forth. There's also literature that shows that cognitive functioning appears to be impacted by trauma exposure. For example, in early childhood, exposure to domestic violence and maltreatment has been associated with a lowered IQ and difficulty with executive functioning. Sometimes I don't know, executive functioning, is that a term familiar? Or is that one of the jargony psych terms? So, I mean, it has to do with it's kind of like the master of your brain that has to do with your ability to control your emotions and control your impulses and not act out. And so these, having an impact on those cognitive functioning abilities has obvious implications for academic achievement, ultimately for job options and socioeconomic status. For example, there's research showing that adults who were abused as children are more likely to, as adults, be living in poverty. Internal representations, I know this is a psych jargon term. This also can be affected by trauma exposure. I think of it as the prism through which your experiences filter through and impact how you think about yourself in the world. So children who've experienced trauma, particularly interpersonal trauma, may view themselves as vulnerable and helpless rather than as capable and competent, view others as either not going to be there for them in times of need or as potentially perpetrators or aggressors against them, and to see the world as a scary and dangerous place rather than a safe place. And you can imagine that a child who has those views, who goes out into the world and acts on those views, which are unconscious, may act in a way that is aggressive, even in new relationships, rather than expecting people to be there for them and have a positive relationship. So the literature is pretty clear that trauma exposure has a pretty significant impact on mental and physical health. It's been identified as one of the leading causes of psychiatric illness and been linked to all of these different diagnoses that I've listed above. And so post-traumatic stress disorder is an obvious one, but also substance abuse, disruptive behavior disorders, which are things like conduct disorder, where you're getting into trouble with the law, and personality disorders. Unfortunately, it is not uncommon for children who've been exposed to trauma, even if they come to a mental health clinic, to be misdiagnosed, either because the trauma hasn't been asked about or someone hasn't made the link between the exposure and the behaviors. So children may be identified because they are causing problems in the classroom because they're acting out, so they get labeled with a disruptive behavior diagnosis or ADHD. The trauma gets missed, and then the treatment plan gets focused in the wrong place. Physical health outcomes is just a small part of the talk, but it also seems to be impacted. So there's disruption to immune functioning and even lifetime risk of disease. So for example, being exposed to stressors in early life has been linked to cardiovascular events in much later adulthood. So because of time, I can only briefly touch on this, but I wanted to not ignore the issues of race and ethnicity. There's some emerging literature suggesting that when you look at the group level, that there may be differences in the impact of trauma exposures between different racial and ethnic groups. And it's really not understood why there are these differences, and a number of hypotheses have been put forth. One is that certain groups are exposed to higher levels of adversity. Another is that certain groups experience ongoing discrimination stress that just adds to the ongoing stress level that they're experiencing. Reduced access to buffering resources, different styles of coping, and even differences in underlying physiology, which again, we don't know why that is. It could be traced back to different stress exposures that start early in life responsible for these physiological differences. So we definitely need more research in this area so that we can have interventions that are as tailored as possible to the needs of the people that we're treating. So now I want to switch gears a little bit and talk about intergenerational effects. So what happens when these children who've been exposed grow up and become parents themselves? Can the trauma that the person experienced as a child be transmitted to their own child in some way? And what the research seems to suggest is that it can. And so we're trying to understand what the roots are responsible for this transmission. First is pregnancy, which is one of the reasons we study mothers. The pregnancy period is a period of high vulnerability. Women are at risk for exposure to traumas, for example, domestic violence during this period. And also, women are more likely to see an increase in symptoms of depression and anxiety and post-traumatic stress disorder. And the literature is pretty clear that exposure to stress and mental health difficulties in pregnancy is associated with changes in child behaviors. But we're also finding that it's not just what happens in pregnancy that has an impact, that it's really a lifetime cumulative effect, meaning in the research that I do with my colleagues, we go all the way back to the mother's own childhood and find out what has she experienced over her lifetime. And we find even when we control for stress going on during the pregnancy, there's an effect of what has happened in the mother's own history, including her childhood. And this phenomenon has been called prenatal programming, which is the idea that there's something happening physiologically during pregnancy that is potentially permanently programming the developing fetus's brain and other physiological systems involved in stress reactivity and physical and mental health. So the mechanisms by which this occurs are very similar to the ones I've already talked about when a child is exposed to stress. So there's evidence that a mother's history of trauma influences the development of the fetus's autonomic nervous system to make it potentially more reactive to stress. Same with the HPA axis and other endocrine systems. And maternal history has also been associated with poor immune functioning starting at birth. and also to changes in the child's epigenetics, which refers not to the structure of the gene itself, but to whether it's turned on or off, so how the gene functions. And so there are genes involved in the stress response that have been found to be turned on or off differently depending on the mom's history. And finally, we've known for quite some time that maternal stress is associated with perinatal health complications, so prematurity, low birth weight, and obviously those have implications for child health and development. So once the child is born, they're born into a developmental context, and this context can be influenced by the developmental sequelae of the mother's own history of adversity. So immediately surrounding the child is their intimate caregiving environment, those people who are their primary caregivers. And there's evidence that children of parents who were maltreated as children themselves are at greater risk for being exposed to maltreatment, either by their parents or by other adults. There's also evidence that parents who've experienced traumas may have more difficulty establishing what we call the attachment relationship, which is that healthy emotional bonding between the caregiver and the child that supports the child's ability to develop emotion regulation skills. Then when you go out to the next layer of the social support system, there's evidence that trauma exposure can influence the parents' quality of social support as adults. So, for example, I keep mentioning child maltreatment because that's one of the traumas that has been studied the most, so we know more about it. But that adults who have experienced maltreatment as children are more likely to be in relationships that lack stability and are marked by domestic violence, either as perpetrators or as victims. They also may be at greater risk for having weaker connections to friends and to the community, which then means those buffers aren't in place for the child. And then you go out even further, and then there's the economic environment. So I had mentioned that exposure to trauma may increase the likelihood of cognitive difficulties that ultimately impact SES. So now children of parents exposed to trauma who are living in poverty, that has clear implications for these other factors: what kind of schools they go to, what kind of neighborhoods they're living in, what kind of stress they're exposed to in their day-to-day lives, even what kind of nutrition that they are able to access, and exposure to toxins such as lead and air pollution. So in summary, maternal history may influence the prenatal environment and the child's environment, both impinging on the child's ultimate mental health outcomes. But it's important to remember that this is not a one-way street. The child is also interacting on the environment. So if you have a child who either, because of these processes I've talked about, or genetics, luck of the draw, is a child who, it's a terrible term, but we call it difficult child or infant. These are children who cry more, they cry more easily, they cry hard, they're difficult to soothe. You can imagine how that can add stress to the adults in their environment. It's harder to care for a child who has those kind of characteristics, especially if you're a caregiver who is suffering yourself from difficulties with regulation because of your own history. These children can also be difficult in the school setting because the schools don't necessarily have the skills or the time to respond as needed for children who are posing a lot of problems in the classroom. But there is hope. There's always hope after that totally depressing talk. Yes. Okay. So there's ongoing research. So as I mentioned, not all children and families who are exposed go on to develop difficulties. So we want to figure out how do we identify those who are at greatest risk so that we can focus our resources on helping those and supporting those families. Also, by studying the mechanisms, that is, how is it that exposure to stress and trauma influences brain development, influences physiological systems, changes cognition. When we understand those mechanisms, we can develop more tailored interventions that really focus on those particular mechanisms and causing changes to those systems. So the existing research that we have that I talked about already points to many possible points of intervention in the system. And I don't have time to obviously go over all these in detail, but some examples would be stress reduction for women who are pregnant, improving mental health by providing competent mental health treatment, particularly in the immediate aftermath of a trauma, promoting positive caregiving behaviors. And the support systems also play a critical role because they can act as those buffers and compensatory mechanisms. So schools, children spend most of their day at school, religious and cultural institutions, and other forms of social support networks. At the societal and public policy level, there's still a lot of work to do. One is we need to address barriers to treatment for those who are identified or want to receive mental health treatment. We need insurance that covers mental health, and it covers it appropriately. It doesn't cut you off before you finish the treatment, because this can be a long haul, especially if someone's suffered for a long period of time. We also need sufficient mental health and social support resources so that there's someone to actually go see. You're not on a waiting list for a year if you are in need of treatment. Then there's the issue of logistics. If you are a family where the caregivers are working 2 jobs to put food on the table, and you don't have your own car or access to reliable public transportation, and your child's in school, which means the only time that they can be seen is from 3 to 6 p.m., and the clinic's only open Monday through Friday, the chances that you're going to get into treatment and stay in treatment are greatly reduced, if not impossible. So we need to figure out how to meet families where they are. And then there's the issue of misdiagnosis. I mentioned getting diagnosed incorrectly and then therefore getting the wrong treatment. At the next level, there's the child who doesn't even make it into the mental health system. They're just labeled the bad kid. They're the child that in the school is constantly in the principal's office, is the thorn in the teacher's side, is not recognized as the child who's suffering, but as a child who's just acting out and making life difficult for other people. And if this escalates to greater aggression or to substance abuse issues, the child can then end up in the criminal justice system, again, with the trauma never being addressed. So I think there needs to be greater recognition at the public policy level that trauma has very broad effects. I've mentioned cognitive, physiological, brain development, mental health, physical health. And also that trauma contributes to many problems that society likes to think of as individual problems. Poor academic achievement, domestic violence, father violent behavior, and addiction. That these are problems that society often thinks are due to moral failings or needing to just pull yourself up by your bootstraps. And I think that it's a very wrong-headed approach, that we need to think of trauma as a public health problem, not as a problem to be solved by individuals on their own. And ultimately, what those of us in this area really want to see is not spending all our time figuring out how to help people who have experienced trauma, but how do we reduce these exposures in the first place? Because it is all too common to be exposed to trauma in the United States. Thank you. Okay, perfect.
Good afternoon, everyone. It's an honor to be here speaking with you all today, and I think that was the perfect segue into my talk, and I guess we'll find out later whether or not the connection is as concrete or makes as much sense as it does in our head. So I'm based in Baltimore, and just came up for the day, and just a few weeks ago had the honor of visiting Boston and working with the Boston Medical Center, the Boston Public Health Commission, and several community-based organizations that are really working to reduce trauma and to reduce violence in Boston. So I do want to just say there is a plethora of expertise here in your community and a lot of amazing work that is happening. So my goal today is to talk to you about why violence is a health issue. Talk a little bit about the Cure Violence model. Has anyone heard of it? Oh, okay, good. This is good. Sometimes I get there and it's 95%, and preaching to the choir. All right, and I'm going to talk about the health approach to violence as a whole and really talk about what we can do, not only as individuals, but really to get up to that societal and policy level. Make sure this clicker works. There we go. Okay. So the World Health Organization has defined health as a complete state of physical, mental, and social well-being, and not merely the absence of disease or infirmity. So when violence is present, all of these things are impossible. So I could just stop there and say, done, violence is a health issue, right? But I'll keep going. So epidemics. I think we could all agree that epidemics is a health term. And what does it mean to be an epidemic? So violence clusters like a disease. So on the top left-hand side, you'll see cholera on your left and violence on the right. And in pockets of our communities, you will see violence clustering, as you would for cholera, as tuberculosis, as the flu, etc. It also spreads like a disease. So in the flu, we know that the more we're exposed to flu, the more likely we are to get it, the more receptive our body becomes. We also know that monthly, it's different, right? So in the winter months, it's actually we're exposed more often to the flu, whichever strain it is that year, and we are more likely to get it in the winter, versus that is true for the summer for violence. Violence is transmitted from person to person, and oftentimes this happens through mirroring or social norms. So when we are constantly exposed to violence, it actually changes our brain and actually becomes normalized. And so in the bottom picture, it's kind of hard to see, but you have a mother who is punching a blown-up clown, and then later you have a daughter who's doing the same. How do we learn to walk? How do we learn to talk? How do we learn to do anything? We actually mimic other people. And so violence is similar patterned. Exposure, as Michelle talked about, is critical here. Why would you think that 30% of people who have been abused as children end up becoming child abusers? That's not a conscious decision. That's not something that one wants to grow up to be, right? And one has received the pain of being abused. Why would that then be transmitted later on? It's not conscious. And then you think about chronic exposure. So people who experience one instance of violence, we talked about the buffer zone. It is dependent on which type of violence. It's also dependent on what your buffers are. But the more often you are exposed, the more likely you are to become involved in violence later on, to the tune of 30 times higher. So 30 times more likely to be a perpetrator of violence if you are chronically exposed. And then we think about combat nations. So post-wars, we've looked at the data across nations and saw that after a conflict has ceased, violence in combat zones actually spikes drastically. Again, it's an epidemic. And in some communities, it's actually worse than others, particularly our communities of color. And so Michelle talked here about some of the hypotheses behind that, but it's actually, again, getting worse. So violence as a whole is down across the country, but that does not mean that we are done. That does not mean that our work is, we should brush it off and say it's time to go, because it's actually getting worse. And the disparities, the differences, and I like to say inequities, because there is societal implications here that make it unjust, are really widening. So in 1985, Margaret Heckler, who was the Surgeon General at the time, issued a report to look at the disparities and took the top 6 causes of death at the time and analyzed the difference between the black population and the white population, and saw that on average there was a small difference between populations, let's say. So cardiovascular disease, 20% difference. And then 30 years later, 30% difference. So that's actually the only other disparity that has gone up in the last 30 years. And I think we could all agree that we've seen campaigns on cardiovascular disease, we've seen campaigns on diabetes, infant mortality. There's been a lot done from public health status around these issues. But the difference back in 1985 for homicide was 400%. It's now 470%. So it might be 18%, which might not seem that much, but our baseline is terrible. And how often do you really think about and hear about the public health field or the health sector in general really being involved in this space? So my goal really is to employ all of you in your fields and your communities in general to really engage with the health sector if you're not already in it, and really to have hospitals, to have health departments, to have mental health and behavioral health, and all sectors really engaged in using the health approach to reduce these inequities. So at Cure Violence, we use the World Health Organization model of stopping contagions or stopping epidemics. And we do this in 3 ways: interrupting the transmission, preventing future spread, and changing norms. Has anyone seen the interrupters? All right, it might be the same 4 people that know of Cure Violence, so that's good. So you're thoroughly involved. So Interrupters is a documentary about the Cure Violence model. And so we work, has anyone heard of community health workers? There we go, a few more hands. All right, so our interrupters are our community health workers. They are on the front lines of this work. And these are individuals who are embedded within the community and have been involved with violence in the past and understand the dynamics. They know who's at risk. They know what to say. They know when things are about to go down, and they actually step in without guns, and they stop conflicts before they're about to happen. And we've reduced violence by upwards of 70% in some of the communities that we're in. And then we work to change the behaviors. So we don't just stop violence there, which we know is good, right, because you're reducing an exposure, potentially not just between those 2 people, but all the potential witnesses that could be involved. But then we start to change the behavior because likely those 2 individuals are still at risk. And so we work to talk about healthy ways of mediating conflict. We talk about skills, we talk about practice, we talk about jobs, we talk about housing, all the different ideas to further engage with our communities. And then finally, we change norms. So does anybody remember a time when we could have potentially lit up a cigarette in here? So that happened, right? That was a thing. And the norms around smoking have changed drastically, right? It's not acceptable. And so that's our end goal with violence. When somebody thinks about violence, when somebody starts talking about it, when anyone exhibits those behaviors, it's just stopped, right? That face, if somebody was to light up right now, I think we would all turn, probably the conversation would shut down, and we would do something about it. We would all feel compelled to, right? And so we want to get to a space where violence is not acceptable, where it's not part of our day-to-day interactions. And this is happening across the country. So there is hope, and not just with the Cure Violence model. I'm going to talk about others as well. So we are in 64 communities across the country, and we are in another 7 countries across the world. And we're seeing drastic reductions. So upwards of 70% reduction in homicides and shootings. We're also in Iraq, where we've done over 1,000 high-risk mediations. We're doing trainings in Syria. We're also in South Africa, in Cape Town. And we've worked in jails and schools and communities and homes, etc. In Chicago, 40 to 70% reduction. I know this is right now in the news. 512 homicides, I believe, so far this year. And so we are right now in 1 community. We were in 20 communities as of 10 years ago, and we had reduced 20% of homicides and shootings across those communities. And so we're in the midst of trying to figure out how we can be back up and running in multiple communities across the city. As you know, the criminal justice system, the schools, everyone is really engaged in this conversation in Chicago to see what can be done. But this isn't just Chicago, as we all know. It's my home in Baltimore, Memphis, Milwaukee are all experiencing some drastic spikes. So obviously, there needs to be a significant change. And what I'm going to argue is that it can't just be a model. It can't just be a program, right? So, you know, obviously, this is prime example. So we did great work in Chicago, but funding comes and goes. And so we need something that's sustainable and a system-wide change. In Baltimore, there's been a 56% reduction across our sites. We are in 4 sites. And then we just lost funding for all 4, and we're back up to half funding. And so hopefully next year we'll still see the same numbers in terms of our reductions. But again, same issue. And in New York, we are in 18 sites, and there's been a 20% reduction across those sites. In some of the neighborhoods, they've gone over a year without a shooting or a homicide, which in many of these communities, I talked about chronic exposure, that was unheard of. I mean, Cherry Hill or Park Heights or Sandtown, Winchester, where Freddie Gray was killed, we just set up shop there. In the first 60 days, there were only 2 instances. And like I was introduced by Robert, I used to work for the Mayor's Office on Criminal Justice. And right after the uprising, there was complete mayhem in our city. And so everyone was saying, what do we do? What's the right, intervention? And for the police, the unrest, really exacerbated the distrust and the relationship issues between the community and the police. And so, part of the solution, not the full solution, but was to put the cure violence model into Sandtown, Winchester, and at the same time work to remedy the relationships with the police. And so when we were in more neighborhoods in Chicago, you saw significant reductions. So this is hotspots. Has anybody seen hotspot mapping? Yeah, oh, there we go. So you'll see on the left and the right the difference. Pre-intervention, post-intervention. And so 40% reduction, 24% reduction, 15% reduction, and all in the major zones which we worked in. And retaliatory shooting is huge. We 100% drop in retaliations. So when I talked about spreading, so it's exposure, but it's also when one person shoots one person, then that person is attached to other people, and then those people are likely to go and retaliate, right? So how do we, again, interrupt and stop that? We've proven that this works. I will say that the slides are going to be available. They'll be posted online, I believe, so just to let you know, because I know I'm almost out of pictures as well, so I don't want you to have to take them all. So this is also working across the world. So Cape Town, South Africa, you'll see in the blue line, that's where we are for cure violence. So reductions in killings, attempted killings, and serious assaults. And then, many people will say, well, how do you know it wasn't another intervention? So we had controls put in place. We've had 4 independent evaluations as well to prove this point. And you'll see there was actually an increase in many of the communities in the control groups. In the UK prison, we were actually only in the prison 2 to 3 days a week, only for 2 to 3 hours at a time, talking to those who were most at risk for being involved in violence. And here you'll see that there was a 95% reduction in group attacks within the prisons. 50% reduction in fights, 52% in assaults, and 51% in overall violence. In San Pedro Sula, Honduras, has anyone heard of it or know why it's famous? It's the most violent community in the entire world. We have been there since 2014, and at one point we had 17 months with 0 shootings in Zone 1. And I could get you this information if you need it in terms of where we are, but they are the most violent neighborhoods within San Pedro Sula. So our overall goal, we have a model. We've learned so much from this model that health approaches work, that, when Michelle talked about how oftentimes women and pregnant women in particular are studied and men aren't, and not that they don't need to be, but they're not. That's kind of the mindset a lot of times, that entire parts of populations have been written off and said it's too late, that they're already too far gone, they're too traumatized. This is not true. It's absolutely not true. This is not bad people in bad places. This is a health issue, and this is something that can be solved. And Dr. Gary Slutkin, who is the founder of Cure Violence, would say that this issue has been misdiagnosed. And so it is a public health issue, and we've placed all of the emphasis on the criminal justice system. Not to say that the criminal justice system doesn't have a place, but public health and health in general plays a significant role here and needs to do more. So we want to move away from moralism, bad people, bad places. I mean, what do you see when you watch the news? It's the same story over and over again, and we're just feeding into this rhetoric. We want to move away from this. We want to talk about contagion. We want to talk about adverse circumstances, and we want to talk about science. And it's starting, so there is hope again. So many articles, many leaders are in this space. Here's a quote from Hillary Clinton: "The Orlando terrorist may be dead, but the virus that poisoned his mind is very much alive." So this understanding is starting to catch on. And now we need the systems change to follow. America's public health crisis, this is Dr. Lena Wynn out of Baltimore. If you don't know who she is, look her up. She is a major powerhouse in this field. Again, U.S. police killings are a public health concern, says researchers from here. And Dr. Sanjay Gupta of CNN, this is an epidemic. So many people are starting to talk about it. Many people are starting to say, yes, there are pockets like Cure Violence, like Boston Medical Center and Boston Public Health Commission, and out of Philadelphia, there's Healing Hurt People, and Youth Alive in Oakland, and San Francisco has a trauma response plan. I mean, there's amazing work happening all across the country in pockets, but what we need is a robust, comprehensive system. And so we have joined forces with hundreds of leaders, including members of the panel and from Harvard as well, to really talk about what this could look like. And Dr. David Satcher, he's a former Surgeon General of the United States, Dr. Al Summer, the former Dean of the School of Public Health out of Hopkins, and Dr. Gary Sluckin are leading this effort. So we're designing a full-on framework of what it would look like if violence was unacceptable, if violence was looked at like it was the flu, if violence became a full public health issue. So we have over 200 partners. I won't ask you to read through all of this, but happy to share who they are. And also happy to brainstorm with you as to who you think really needs to be involved. And so we need this movement to really move us away from racial biases, inequitable treatment, criminalizing of entire communities. Ben Jealous, former NAACP president, said recently, we criminalize entire communities and victimize other communities. And so we need to move away from this and really start treating people fairly and looking at this as a health issue. We want to move away from facilitating the abuse of power and further traumatizing individuals through systems and through individual interactions. And we want to open up understanding, funding, and practices for health approaches. And long-term, what this looks like is the health sector in partnership with the criminal justice system, ways to work together using an equity lens, violence reduced across the board, and we believe that it could be a 70% reduction in all forms of violence if we did this right. I'll leave that there. Thank you.
Thank you. That's the perfect segue, I think.
Planned it.
That's right. Hi there. Good afternoon, everyone. My name is Fatimah. I just want to take a moment to thank Dr. Kinsherff and the Petrie-Flom Center, CLBB. This is an amazing panel. I'm so honored to be here. I'm from Equal Justice USA. We're a criminal justice reform organization that spent the last over 25 years on repealing the death penalty in this country. And we've done so in pretty innovative ways. We've engaged what we call unlikely allies from the evangelical community, conservative, progressive communities, and really specialize in state advocacy. So I'm here to talk a little bit about our new work. I'm the director of the Trauma Advocacy Initiative that really looks at race, trauma, and disrupting the cycle of violence from an advocacy perspective. So I want to talk a bit about a really important piece of our work, which is engaging crime survivors, so those who are victims of crime, and our focus for these last 10 years has been family members of murder victims. And in our organizing work, what we've learned is that in the wake of violence, a lot is said on behalf of victims, and often the most aggressive punishments are called for in the name of victims, particularly victims of violent crime. But when we talk to victims, what we learn is that what they want most is healing and rehabilitation in their communities. And that message that we heard over and over again became all the more powerful on state campaigns when crime victims spoke with lawmakers about what their true needs were. We're really happy to share that our partner organization, Alliance for Safety and Justice, formerly Californians for Safety and Justice, has just released a report of a national survey that was conducted of crime victims and found that over 3/5 of crime victims, when asked what they prefer in the wake of violence, prefer shorter sentencing, and greater spending on prevention and rehabilitation. So that data is available, and it really reinforces something that we've learned over and over again in our organizing work. So what we believe deeply is that understanding trauma, is a part of a larger frame of analysis, something that supports us in our work addressing these issues out in the community. And so what we're called for, and Robert mentioned, is a trauma-informed justice system in which we understand that trauma is not just experienced by victims, but is part of the cycle that we previous panelists have mentioned, for families of those who've been incarcerated, for young people, law enforcement, corrections, judges, that they're all experiencing some form of trauma, and that when we expose this as a frame of analysis, we see the entire criminal justice system as broken. And so, given what we understand about the science of trauma, can we imagine a justice system that is responsive, that understands deeply the science, and it reorganizes itself around the true needs of those constituencies? So what might that look like if we use trauma as a frame of analysis? So forgive me for those of you who are graphic designers. This is a course. This is a course figure that I drew that I think it at least punctuates the point. So forgive me, but when we think about who is touched in the justice system, we often let's see if I can do this pointer. We often focus on those who harmed, right? That we call offenders or justice involved. And there are so many other pieces of this system that comprise the system, right? So we mentioned crime survivors here. There's the community. There are the service providers, and that is a really broad term that includes anyone from first responders, law enforcement, social workers, case managers, a whole range of people who are on the front lines. But then we also have a historical context. We understand, and I think there's a greater understanding of the criminal justice system, and in the context of America's greatest sin, right, slavery in this country, and there being, I think, more conversation about those links. So we add that to our analysis, historical trauma. And of course, the system itself, that being involved in the system itself actually exacerbates trauma. So if we use trauma as a frame of analysis, and we were asserting that we wanted a system that could do differently, responding to what we understand about trauma, what might that look like? Well, for those who were harmed, we would we'd aim for restorative justice and accountability. And here we're defining accountability as an experience in which someone has named the harm, they've taken responsibility, that they have made promises to for forward action, and in restorative justice model, there are a number of parties involved, including in some models, right, crime survivors, those who are victims. And that we are partnered with organizations that actually do restorative justice work with violent offenders, and have asked those who have been participating in the process, particularly victims, if they would recommend this process to others. overwhelmingly, over 90% say yes, that this has been really powerful experience for those who are in the process itself, and that what ultimately arises out of the conversation is what people feel is true accountability. For crime survivors, for victims, witnesses of harm, there's healing and support. There's a real true understanding of what that looks like. So in our country, we have, for many of you, how many of you have heard of the Victims of Crime Act and victim services? So I see a few hands, that there is funding available for those on the individual side, compensation for property damage or a loss of a family member, that there's compensation that an individual can apply for. There's also social service providers that also can receive funds. Several years ago, Congress actually increased the cap on the amount of funds, so we're over $2 billion of available funds in the wake of any sort of crime, that not just violence, but a range of crimes that qualify for this funding. And we are really working with a number of other partners on bringing racial equity to access to that money on the service side, because service providers, particularly in communities of color, particularly in marginalized, hard to reach, that are less likely to utilize more mainstream services, we are finding the providers that specialize in those marginalized communities, and we want to make sure they have access to the resources to continue to do the good work that they're doing. So we're involved in that. For the community, we want greater trust and safety, and I'm sure many of you have heard of procedural justice. So I won't go too much into this, but I think this is where our conversation about prevention, rehabilitation, reentry, that the community cares about those issues, and we want to be sure that we're doing them in thoughtful ways. Again, history, very important to acknowledge history, and I mean kind of history in a broad sense. Our social history in this country, but also localized history, that there are particular issues, the ways in which redlining has happened in particular communities, that there are broader social determinants and policies that have really harmed communities, and an acknowledgement of history gives us an understanding of current ills. And finally, the system itself. One more? Oh, the system itself, right? We want to see the system itself transform, that we understand that those who are involved in the system, again, judges, law enforcement, are burnt out. Vicarious and secondary trauma is a huge issue, getting greater and greater research, and we want to see systems actually respond in meaningful ways so that our first responders are doing the best, and I add that here. So training and wellness for those service providers. So how do we get there? We are really excited to talk about the elements of a movement, because I think that one of the key pieces here, and I'll share this in a moment, that many people think that movements start and end with the first two pieces that are important to a movement, but not the only pieces. And that is good research and information, right? People will come, and there'll be a release of a study. There'll be a really important report, and those of us who read those reports think, my God, this information's amazing. It's going to change the world. It's going to really change the way that we think about X thing. And then we're dismayed when no one's talking about it, no one's read the article, and if you pointed them to the article, and I'm sure this has happened for some of you at kitchen tables, we say, well, read this report. What happens? Have their lives changed? No, they don't read it, and maybe if they glance at it, it doesn't necessarily change minds and hearts. For those of us who care about research, it does, and it's not to disparage. We need the research. We need the facts, but they alone are not sufficient to inspire the kind of change that we've seen in this country. Likewise with proof of concept, that there are a number of best practices. These are the programs and models like Cure Violence that are doing incredible things. And again, you see the data and you're like, so compelling, so compelling. How could anyone not, with a program like this, if I told you, if you invested $5 and it can make you $1 million, of course you would take that, right? Well, essentially what we're learning is that lawmakers in many places, when you provide that kind of cost-benefit analysis, are still saying no. It's shocking, right? It's really hard to imagine, but that is precisely why movements do not rise and fall with information and proof of concept, that there's much more that's needed, and I want to talk about those other things. So narrative shifting, what does that look like? So Shannon mentioned smoking, and I think it's a great example of the progress we've made in the last 50 years in this country, the way in which we think about smoking. So I just thought I'd add a few ads, right, on the right, on the left, a doctor recommending, right, to have a cigarette makes you feel better, decreases stress. And the anti-smoking ads have gotten so intense, right? They're really powerful. There were a few, as I was kind of looking for images, I couldn't believe how intense these right? And they're still smoking in this country, but the norms have changed. Our understandings have changed through really aggressive campaigns that have happened in this country. AIDS, another great public health, particularly around our ideas about those who have AIDS and whether we, the moral argument, right, on the left, right, AIDS is the wrath of God, right, on the one hand, and then the we all have AIDS campaign, right, in recent history with, famous stars like Will Smith, Nelson Mandela, of course, in the front, Bette Midler, and many others. So, narrative shifting is a whole constellation of work that, of course, engages media, but it takes a whole range of things. And as our consumers of media get more and more sophisticated, how to target key audiences also becomes more sophisticated. So the use of social and digital media is becoming a huge part of how narrative shifting happens. We also need campaigns. We need policy and systems change campaigns. We need advocates who are working outside as well as inside the system. I firmly believe that you need both working hand in hand. And a clear articulation of goals, right? So when we think about marriage equality in this country, for example, in the early days, there wasn't a coalescing necessarily around marriage as the issue. There are many other issues in the LGBT community. But once that coalescing happened and there was a clear campaign, it took 20 years to advance the campaign plan. It really does take that long, but it's powerful and really profound when there's a clarity of what the change takes. And I think one of the challenges in our line of work is that we understand trauma, we understand the science, the research is building, but what does that mean? What are the implications for policy? And can we all agree and be speaking the same language about what those policies look like is a challenge for us at this point. But in the identification of it, there's such an important role for those who were impacted, right? So at the grassroots, impacted parties, those who've been incarcerated, crime survivors, families of the incarcerated, that there's a real need for their voices in this work. So we just don't want the Will Smiths and the Bette Midlers of the world changing the narrative. We need voices from the ground also changing the narrative. And finally, there you go. There needs to be a coordination nationally. And this is, again, the piece about how we all can be part of this orchestra, and that there's a real conversation across states, across rural, urban, that there's a real need for folks to continue to talk to one another. And that's precisely what forums like this are designed to do. I think there's a real role for universities to be spaces in which such ideas can happen. And I'm very excited that more and more of this is happening. And I hope that we continue to do this in the future. I think I'll stop there. And I really appreciate the time. I look forward to questions. Thank you.
So I've learned we're going to have a little bit of time after the half hour, 5 minutes, 7 minutes or so. So we'll have some chance for conversation before we go over to the pub for the gathering of the Petrie-Flom. But I just want to let folks know that if you need to leave, we understand. If you can stay, we'd love you to do it.
Okay, so first of all, thank you, Dr. Kinsherff and the Petrie-Flom Center. It's a pleasure to be here. I've never been likened to Big Papi before, so that's quite something to fall into as the cleanup hitter. And I also feel like I'm a pediatrician impersonating a policy leader, but nonetheless, I'll see what I can do and try to bring some of this together. I do have the pleasure of working in Washington and have some insight into the current policy around this, so I'm going to try to bring that to bear and try to integrate some of the comments from the earlier presentations. I'm going to start off, seeing as several of us have quoted previous Surgeon Generals, I'm going to quote a different one. This is from the late Julie Richmond, who some of you knew. He was a faculty member psychiatrist here at Harvard and Boston Children's and was in government both as a founder of the Head Start program and also critical for addressing tobacco. And he said, in order to change policy, you need three things. And it's, again, very simple model, but you do need scientific evidence about what the problem is and what might work. But in addition, you need political will, which is really what we just heard about from Fatimah, as well as the social structure in which you can move the policy forward and social infrastructure. We should talk about these. And you can each think of specific examples where there may be policies, for example, like climate change, where we actually have really good evidence about what works, what the problem is, but we haven't had the political will until quite recently to really move this forward. You might think about other examples, maybe e-cigarette issues, for example, where we actually, I think, have political will to make sure that's not it becomes a health problem, but we don't really have clear science about what the harm is and what we should be doing. So useful to think about these. Social infrastructure, you might think about this small thing called the Affordable Care Act, and trying to figure out whether, did we do the right thing by using the existing social infrastructure of existing insurance companies and Medicaid, for example, versus creating a different infrastructure for moving forward. So think about that as we think about how do we want to move forward this issue around policy around violence prevention. Now, this is the third presentation, the third session I've been asked to during my brief time in government. I've been in government only for about a year, where I've been asked to talk about neuroscience or brain science, as they say it, because that's more powerful, and X, something related to social policy. The first one was brain science and the intergenerational transmission of poverty. The second one was brain science and youth and how to positive youth development. And this is the third one on brain science. So there's something about brain science that's captured the imagination, not just of the academic world, but clearly of policymakers and of the intersection. Now, when you talk to the real brain scientists, the ones who are doing the PET scan stuff and all that most of us barely understand, they're kind of like a little skittish about it. It's like these policymakers are running way far ahead of the science. But the rest of us say, hey, don't stop now. We need you to push it because it's moving all kinds of interesting things. Clearly, as we heard in the initial presentation, brain science is influencing political will because it's starting to change the narrative. Again, it's changing the narrative about bad people causing crime. It's changing maybe the narrative that criminal behavior or violent behavior is the inevitable result of inadequate parenting. More has to do with the environment and the context in which families live. That it, on the liberal side, it may be changing the perspective that says simply not having enough alternative means of earning a living is really the explanation for violence and crime. It could also be influencing some of the policing strategies. It says toughness is the only effective strategy when you realize that you're interacting, that at least police are interacting with significantly traumatized populations, and doing that sort of toughness approach is not going to get the kind of reactions that they might otherwise be expecting. But there are risks to this concept, and they've been touched on a little bit. We might talk more. Much as brain scientists always say biology isn't destiny, there's still this implication that, boy, when you've experienced, 4 adverse childhood or 7 adverse childhood experiences growing up, that you're damaged goods. So we talk about fighting that, but we need, I think, to come up with a better way of strategizing. Another challenge that I see with the brain science emphasis in changing the narrative is it leads to social service interventions. It leads to teaching parents how to do serve and return. It leads to parent education programs, all of which are tremendous and are biologically based and are really important. But it doesn't challenge the assumption that says, and we really should be addressing fundamentally poverty, and we really should be providing housing for families. And we really should not accept that what we need to do primarily is buffer the adverse experiences that families have. So it's a balance. Now, again, most of us who can think two thoughts at the same time would say it's a both and, not an either or. But it's just a danger we need to be aware of. We heard brilliantly and far more knowledgeably than I can talk about the importance of building a grassroots movement to build enthusiasm for change, and especially involving people who are directly affected. The two most powerful experiences I've had, or two of the most powerful experiences I've had in Washington, has actually been when we have brought, for example, children of incarcerated parents, youth, who can really tell you what it's like to grow up and what happened when the police took their child while they were there and witnessing it, or what happened when they couldn't talk in classroom about where their parents were and why they couldn't sign the forms. Or similarly, when I talked with individuals who were coming out of prison and trying to get jobs and talked about what their experiences were, both the successes and challenges. That kind of power from those kind of authentic voices, as we often call them in the healthcare setting, is incredibly important. We also have to recognize these windows of opportunity, which we've had. I mean, the bad news is we've had terrible windows of opportunity. Baltimore, Ferguson, Dallas, Baton Rouge, where violence comes to the fore. But that also means violence comes to the fore, and preventing that is critically important. I mean, the reason I think of Honduras as your example is part of my scope of work entails how do we care for the unaccompanied youth coming across the border from the Northern Triangle, from Honduras, El Salvador, Nicaragua, and Guatemala. And clearly it's rooted in that same violence. We fortunately have motivated leaders at the present time who are really engaged in this. We have a president who really understands at a gut level what this means. We've had two attorneys general who, this isn't a casual issue for them. The issues of violence, how it has a disparate effect on the African American community in particular, is in their gut and critically important. And I think that's opened all kinds of opportunities. And there's a convergence of interests around this. And again, you might have very disparate bedfellows who have very different thinking about all kinds of issues. But some of them may be cared about just the impact of prisons on the budget. And how can we reduce that, compared to other folks who may be, from a more liberal perspective, concerned about other aspects of prevention. And we should be taking advantage of that and thinking about how that may or may not change in the upcoming political situation. Now, the brain science really doesn't specifically give us evidence about what works and what doesn't for change. It tells us what the problems are, but as you mentioned strongly, it's often correlational data. But it has pointed to a couple of things. One is what I might call the long game, where you've got a chess at strategy. So early childhood education, clearly a long-term strategy to address issues around the prevention of violence. Clearly parent education and support, and as I mentioned, directly addressing the conditions of disadvantage. There's a shorter game as well, and again, that's what Gary Slutkin talks about a great deal, developing executive function capabilities, decision. I mean, he doesn't use that language, he uses a different language, but it's how do you make decisions in the heat of the moment, and how do you build those capabilities in the youth and young adults who are the ones who are most frequently involved in violent activities. And clearly recognizing the impact of trauma and adjusting your approaches. And again, this concept is broadly present in DC. I have the good fortune of chairing a subcommittee of Health and Human Services Behavioral Health Coordinating Committee that is developing everything in government, it's like that long. We are developing a guide for human services agencies across the country so that they will be more trauma-informed when individuals come in seeking specific benefits and programs. Cure violence, you've heard, it's a theory-based intervention. Now it is curious that it's based on the interruption of contagion. Those of us who are epidemiologists, it's one of the degrees I'm lucky enough to hold, knows that John Snow actually discovered, the founder of epidemiology. It's completely non-theoretical. In other words, he identified that cholera came from the contaminated well before anyone knew anything about bacteria and stuff like that. So it's just, I don't know, The relationship with brain science, it's there particularly, I think, through thinking about trauma, but clearly it's an important intervention which has incredibly strong evidence of effectiveness. But I want to come back to that and see the funny ways that effectiveness gets played right now in Washington, because it's an inconsistent, at times very encouraging, but inconsistent thing. Another just point to raise, and this relates really more to my work prior to Washington, is thinking about the concept of the fusion of innovation. What good ideas spread and what don't, and what's the characteristic of those good ideas that spread and characteristics of the social context in which ideas spread. And many of you may have read Malcolm Gladwell's book called The Tipping Point. What is it going to take for us to get to the tipping point so that a cure violence-like strategy can become the norm? And I'll touch on that. So just a brief digression on evidence. So on some sense in Washington, it's one of the few kumbaya holding hand bipartisan areas of a deep embrace of the importance of evidence in forming policy. And the current administration has a series of signature initiatives focusing on evidence. And the book that describes in glowing terms the administration's work was written by Ron Haskins. Those of you with white hair know that he was sort of the architect of TANF reform back in 1996. He was involved with Reagan and stuff like that. So he's writing about this. And the idea, the two signature initiatives behind this tiered evidence program are the home visiting program and the teen pregnancy prevention program. And the idea here is you identify things that work, and work is sort of narrowly defined, and then you bring them to scale by investing significant amount of money, and then you typically would reevaluate them or evaluate them as you bring them to scale. And you also dedicate a modest amount of funding, usually about 20 or 25% of the overall funding, to promising interventions, interventions that have quasi-experimental studies that show their benefit as opposed to randomized controlled trials. And on the one hand, who could argue against this? It's actually a beautiful thing, and my office actually does the evidence review for teen pregnancy prevention, and we're deeply involved in the home visiting work. And there are more, there's a Ryan Murray evidence-based policy, so Ryan and Murray, again, bipartisan evidence-based policy-making commission act 2016, also working on this evidence. Now, the limitation is that, and first of all, to become an evidence-based program, you only need one randomized trial that shows it works. You might actually have 15 that say it doesn't work, but if you have one that says it's worked, that's okay. And if you have one that says it works on one outcome and 15 outcomes didn't show benefit, that's okay too. As long as there's one thing that says it works, it meets your criteria. And that's why we have 17 at this point evidence-based home visiting programs. I think we have 40-some-odd teenage pregnancy prevention programs. But it does mean, for example, some things that really don't work, like some of the abstinence programs and things like that, don't get funded, and that's a good thing. The other challenge I would see is that what it gets applied to tend to be things that serve poor people and have social benefit. So, for example, you don't see U.S. tax policy, for example, based on randomized controlled data about what works and what doesn't work, and a variety of other kinds of things. So I would be, well, as a member of the administration, I'm firmly supportive, of course, of our tiered evidence-based initiatives, and we'll fight to the death about it. And I know this is being recorded. On the other hand, you do need to be, I would feel better if this strategy were more universally applied. Now, in healthcare, where we invented randomized controlled trials, we also now have this thing of, it not only has to be proven, it sort of has to be proven, but it really has to save money. And that's a different criteria, and save money for the healthcare system. Just as we think about the social infrastructure for just a minute, just to say, I do think that's a potential obstacle to spread of the model we have, because we're really unsure where to base this prevention strategy. And there are vested interests in violence prevention in the ways they do things, like policing, for example, which is important. And so where does this sit? Do we build on the public health infrastructure? Do we build on the human services infrastructure? Should it be part of the educational system? I think we really need to sort that out for this to work. Now, I wanted to spend time telling you about the incredible amount of federal activities that are actually underway in this space. But if I do that, we won't have any time for questions. So why don't I stop here? And if people want to know about what federal programs have been influenced in this arena, I'm more than happy to talk about it. So left
So, Remembering that you have to wait for the mic, we'll get our folks out there with the microphones. Take a second to formulate a thought, comment, or question. Okay. Is yours live also? Excellent. Comments, questions, expressions of moral outrage. Dr. Homer, would you care to tell us a little bit about what's going on?
So I'll just flip through a few. So one is, people should certainly understand that the early childhood message has been heard loud and clear. So we do have a Head Start program. It serves millions of children. We just issued, just last week, new performance standards that will move Head Start from being part day, part year to full day, full year. So that kind of, we've created partnerships between early Head Start programs and child care centers around the country to enhance the strength of those child care programs. We've invested in what they call two-generation strategies, so not only focusing on the child, but simultaneously developing executive function capabilities and employment skills for parents, a number of programs around that. Very excited, we just published this on the 100 days of the Federal Interagency Reentry Council, which is cross-government, multiple efforts to promote the reentry of individuals from incarceration into society, all kinds of exciting ideas. We've created things called Mythbusters. For example, the myth that you can't go into public housing based on a past felony conviction. This is a Mythbuster around confined youth easily return to school. Related to the ACA, as part of the reentry work, we did a lot of work on providing, people may not be aware, but because of the expansion in those states that have chosen to expand Medicaid, poor adults over the age of 18 are now eligible for Medicaid, and they weren't before. So that means individuals coming out of prison who have a very high likelihood of having either mental health issues, substance abuse issues, or issues like hepatitis C are now eligible for care. And we've done a variety of things to facilitate their access to Medicaid. The federal agencies now have a ban-the-box approach in our work. You know the president has this My Brother's Keeper initiative, which is focused on individuals of color particularly, but not only young men, and a variety of activities around the country on that. We also have something called Performance Partnership Pilots, which is a program for, quote, disconnected youth, that is people between the ages of 18 and 24 who are neither in school or working. And what this program does is it allows blending and braiding of funding. One of the things one often hears complaints about is that we'd like to do this, but your rules don't allow us, and this is an initiative that allows sites to blend and braid a program. So those were some of the ones I quickly wanted to mention.
And for the sake of the recording, could you just repeat the question into the mic? What the question was?
Would you please let us know what public programs are being funded?
Thank you so much.
Thank you. Over here. Oh, I'm sorry, go ahead.
I'd like to know from Dr. Michelle Bosquet, what age is the most traumatic in causing potential problems in adults, as well as prenatal. I think it's during pregnancy as well as prenatal risks for the women to get into this problem, but just focus on what you can give us for the highlights and where's the worst problem.
Okay, I wasn't sure if I had to push something. So as I mentioned, I think that there is an interaction between the type of trauma and where brain development is when the trauma occurs that would impact that. So there's not a clear-cut age at which a trauma exposure is going to be most damaging. But at least from my understanding, it's the fetal period in those first 3 years of life when the brain's developing particularly rapidly and when it's particularly open to experiences that can then become permanent. So it's not to say that those experiences, effects can't be modified or even undone later, but it could be more challenging. Adolescence is also another period where the brain's undergoing another period, particularly the prefrontal cortex, which is responsible and heavily involved in the executive functioning we've been talking about, which is why adolescents don't really control their behaviors very well because that part of the brain isn't fully developed. So that's another period when exposures can have impact because of what is going on in the brain at that time. Did that answer?
Thank you. Ola, you had your hand up? Yes.
My question is in terms of moving policy. I'm a strong believer in grassroots, but the people that we're trying to move are the people in power who don't often come from these groups. So how do we get to the judges and the lawmakers who are affected by solipsism and only know their experience and can't understand why then people who are poor or people like, why can't you just get a job? Why can't you just stop killing each other? Where it's all about kind of individuality and pulling yourself up by your bootstraps without regard for the affirmative action of nepotism and money and wealth. So how do you get to the people in power? Because the people who are electing, the people who are judges, who are in the criminal justice system, who are making the laws, don't get it. And so what education is currently going on and what can we do so they can get it? Because that's where we need the movement.
Fatimah, you want to take first crack at that?
It's a great question. And the truth is that it requires a range of messengers. So we don't assume that, if the target is a particular judge, that it may take another judge from another jurisdiction that judge respects, that's the messenger, right? It's a credible messenger. It may take a particular law professor, right? We don't know, but it may take that law journal article that, really changes the, I think that academic communities in this regard have a tremendous influence on these things over time. So we don't want to assume that it's just grassroots that's going to impact all communities, but grassroots is a critical piece of it. I think the work, excuse me. Logical. I'm usually good at saying this word. Research. So an example, pointing to violence as a contagion, right? A social contagion that behaves in ways like a disease. Theoretically, and the research that points to this is quite powerful in certain circles and could be really hard for people to understand in others. So I think that we have to be really careful around the messages we use. You mentioned punishment. I mean, one of the prevailing paradigms of the justice system is that it's designed to punish those who've done harm. It's a really challenging frame to change in this country. I don't want to dismiss that. And it's an uphill battle for us to change, ideas, cultural ideas about what justice is. But I think that those things are changing. And I think accountability and the idea of rehabilitation, mercy, those ideas are quite profound. And in our work, we engage with conservatives and evangelicals, particularly around the death penalty, and it's been powerful narrative-shifting work to see a conservative argument against the death penalty, and evangelicals talk about redemption, right? Very different kinds of messages for different communities, but have been powerful for our work. So, great question.
We'll take two more. I'll take this gentleman here. Oh, you had her hand up first? Go ahead. And we'll cap off with this gentleman. Go ahead.
So I've worked with incarcerated youth, and I watched them be very vilified when really, if you start looking at it, they've huge trauma history. I'm actually going to play devil's advocate. I sometimes wonder if the police that are engaging in some really inappropriate behavior sometimes may be traumatized. And it's not to say that what they're doing is okay in any way, shape, or form, but if trauma is a piece of it, and we need to offer them some healing and support and change social norms. How do we do that? And how do we do that in light of the fact that sometimes there are forces like unions and et cetera that make that a little harder to get to?
I'll toss that one to Shannon because you've worked with law enforcement in the communities where you've been working.
Yeah, I'll start, and you might have something to add, Michelle. So I think one example specifically is in Texas, where the individual responded to a group of teenagers at a pool party. I'm sure you all saw this on the news. So that police officer was coming from a double homicide, suicide, right? So just came fresh off of a super traumatic experience and walking into, a group of adolescents, if you will. Not saying his behavior is okay, but what should have happened in that instance. And so, that cooling off period, that really being able to relieve the stress and start bringing down that cortisol level, not going immediately into, another scene or responding to another issue. And so, I think there are protocols that are starting to go in place, and especially as, unfortunately, we see more and more incidents across our country. And so some efforts have been in place to deal with the vicarious trauma. So, there's some police departments, specifically in Chattanooga, Tennessee, where they are working to bring trauma-informed care across the entire police department. And so they have social workers on staff to work with the community, but also to work with the police officers. And if a police officer is responding to a traumatic incident, then it is mandatory that they go in and speak with somebody. There's also healing circles and so on and so forth.
So I'm going to stop there just because we're going to have one last, we'll do a speed dating version of this. And then we can continue this conversation at the hub, at the pub at the Petrie-Flom event.
My work involves health data, and there's a troubling trend to blend law enforcement data, public health data, and clinical data into combined systems for all sorts of reasons. It seems to me like this is a very short-term issue that's getting ahead of the science and the other issues that, the will issues that you talked about. What's going to happen there?
Dr. Homer, do you want to take a first crack at that one?
Could you say a little more about your concerns?
Well, traditionally, in the paper records days, law enforcement data was separate from clinical records, and public health officers had yet a separate jurisdictional governance mechanism around policy. And what we're seeing now is a rush to combine these data sources to make law enforcement data more accessible to clinicians, for example, and maybe vice versa.
Can I just ask a question of clarification? Are you talking about the creation of large data sets for data mining purposes, or are you talking about initiatives, for example, where somebody may have had a history of a psychiatric disorder who engages in active violence, then the gun registry people are talking to the law enforcement people who are talking to the clinical people around say gun control. I'm just
two
using
examples would be gun control and prescription drug monitoring programs.
Okay.
Well, I guess I'm not sure I'm expert to speak in that. I'm certainly aware of efforts to bridge the data. I can certainly, given that in fact much of the same many of the same underlying issues drive both substance use and criminal behavior, and often the stresses that lead to mental health issues. The idea of being able to, for example, identify who might be at risk, who might be costing the system a great deal of money, and who might be in need of services doesn't deeply trouble me. The idea, perhaps, that there would need to be appropriate privacy protections, for example, that individuals' mental health counseling records and things like that shouldn't be accessible to police necessarily. On the other hand, you would like actually a policeman to know that if this person has a significant mental health history, you would actually like them to know that as they approach that individual. So I guess given appropriate training and concern, I'm more in favor of what we call interoperability than I am opposed, and I'm in favor in general of creating analytic data sets to identify areas and opportunities for work. So I may be missing a point that others might be more aware of.
I think I just want to say there's underlying your question is about trust, that these systems, that all of these systems really have embedded in them challenges and kind of can reify systems of oppression And the idea of meta systems kind of forming using data to propel oppression is a concern. I think it's a valid concern, and I think we've not, when I heard you say catch up with the science of it, I think it's really how do we get ahead of those potential ways in which data can be used in ways that just reinforce oppression. And I think it's a really important thing we do need to be thinking about and paying attention to.
And on that very interesting and provocative note, let's thank our panelists.